It is my pleasure to introduce Raj Godavarthi, board member with WEDI and AVP of Technology and Interoperability with MCG Health.
Good afternoon. It's pretty hard to get audience after lunchtime, but I really appreciate you guys being here. I hope some of the details we share will be exciting. Really fascinating to see the other presentations this morning. We hope to share some of the insights from several implementations we have done on the prior authorization, especially the proposed and the finalized CMS rule and everything coming out of HDI 2. So a lot going on in the healthcare industry, but prior authorization and automation, interoperability is in center of most of the payers and providers implementations lately. So I have been with MCG for a long time. MCG is known for their evidence-based guidelines, primarily used in the continuum of care, largely for the utilization management purposes. We have nearly 7,000 customers. Majority of the US health plans use our content, and majority of the US hospitals as well. We are known for the gold standard of evidence-based guidelines to take care of patients in the continuum of care. We are independent. We are not regulated by anyone. We have been in the business for almost 30 years. Majority of our customers have been using for almost 20, 25 years. So coming to prior authorization experience, I think we are first in the nation who have done this using a little bit of FHIR and X12 and everything else, and I'll share those details in a minute. By far we have done with 3 payers. Recently we just completed with Highmark, one of the top national payer, and then before that we have done with Cambia in the West Coast and CareSource in Ohio region. Our experience have been in implementing 3 payers. Now we have 6 health networks. When I use the word providers, loosely used, but when I say network, some of these provider networks have 10, 15 facilities, so they're all using it. In a simple sense, like after all the toil, people love the real-time processing, right? We are not there yet completely in terms of scalability and a lot of other things, but just the experience of that I can submit something, I can get something back within minutes is very promising. We are living in the worlds of Amazon. You can buy everything with one click, right? And people are seeing that promise slowly in the healthcare industry despite many challenges. What I would like to share with you is that what we have experienced, and hope some of these things will help you. We have a lot of policymakers here. We have a lot of people listening online. Our hope is that some of our insights will motivate or probably even excite you that we can persevere through this journey, and it's not that difficult in some ways. So, with the 3 different implementations, we have seen between 8 to 21 months implementation time. And if you think about this from the payer's viewpoint, it is millions of dollars they have to invest in terms of getting the systems ready to talk to each other. A lot of these legacy systems are still in place. They can't really change things like the way we talk about. They still have to use them because a lot of other things are flowing through the same systems. But in terms of the coverage requirements and documentation templates, prior authorization, these are the things that CMS, when the rule came, that they recommended to use according to the HL7 Da Vinci group. And then the last bucket was the buffer, bringing providers on board is definitely a challenge. It's not the technology, it is just the change management. It is just that bringing them to say this will work for you. Because they have been using the fax and other means for a long time. Right? They've got used to the workflows. They're seeing the process working, whatever they designed over the years. All of a sudden, now we come and say we can automate everything. It doesn't work. You really have to earn their trust. Right? And trust comes by proving it, and it takes time sometimes. So, we have spent enormous time, even our systems are working, just going to a provider and convincing them this will work. Initially we underestimated grossly that factor. We thought providers would love it just because of real-time processing. So if you are planning this implementation, if you are somewhere in this process, give ample amount of time bringing providers on board. You need really like Anna Taylor and some of the people who are here, the champions on the provider side to carry the torch for you, because they have to convince the organization on the other side. So that's the experience we had. We have shared this slide many times in our presentations. This is our first implementation. Our second implementation we have done with Cambia, largely with the FHIR standards, right? So this is where they have shared the statistics that between CareSource and Cambia initially we implemented, how much time they saved, right? What is really promising is the right side box where the multi-care, Annatel is here, where they used to submit 3 to 5, before, and now they're submitting like 12 to 15 using the real-time processing, and it has gone up since then. We have not captured the details. But with Cleveland Clinic, at some point, between Cleveland Clinic and CareSource during COVID times, they automated everything because of the shortage of staff. They were like 60-70% auto-approving because of the technology that enabled them when the staff is not able to come. So the technology enables automation, right? There is no doubt about that. But the standards, the evolution of standards, the legacy systems, the modernization, they all take time. Like it's as if like we are building the plane while we are still flying, right? You have to keep changing some of the parts, but you can't stop the flight, right? So that's the kind of mode we are in. So I would like to share some of the other transactions just to give you a sense of it. CareSource is one of the payer in the Ohio region. They have been using for 3 years. These are the stats from 2024. So the bottom line represents the things that are auto-approving. Like as soon as the request comes, the response goes back within like 10-15 seconds. Right? About 10% we see they're auto-approving today. They have the controls in place to increase to 16%, 20%, depending on the volume, depending on what's happening in their market. The middle lane represents the number of transactions, number of auth requests providers are submitting in their area between University Hospital, Cleveland Clinic. They have a lot of facilities as well. And the top, trending line represents number of transactions. That means that when you submit an auth request, a payer could say, I need more information. And that is happening through the system. They're still in the same system, whether they're using Epic or whatever it is. So they submit and payer says, I need past history of this patient. They can just send a message like email or a chat, and then it goes to their EMR and they can submit to the same case electronically. So as you see here, for each authorizations request they're submitting, we are seeing an average of 3 transactions, like that back and forth. In today's system, that would happen through fax and phone. And that's where the 3 days to 7 days to 10 days, right? You're trying to catch hold of other person on the other side asking exactly what they would need. And then you gather that from the EMR, print a PDF or send a fax. All that takes time. What we have seen with this real-time interoperable system, that they can do that exchange. Right? It takes time to build it, but the promise is there still, we believe, right? And this particular implementation took us over 2 years. We have done this before the FHIR standards, and the Da Vinci standards came, right? Then MCG evolved, and this is where we have done with Cambia in the West Coast region, and Multicare is a provider network, and they have been using the system, and it is real time, right? So still they're at the 10% in terms of, on an average, that is 10% auto approvals. And they have still the controls to enable like 15%, 20% they want to auto approve. But still, you see the transactions, number of transactions they're doing. Very recently, Highmark, one of the largest payer network, started using our solution. And you see that, they have, on the left side, you have seen the number of transactions by month since we have gone live in January. They've taken like 30 to 60 days to bring all the network, the facilities up to speed. But since then, they have been using consistently, and they have seen a lot of promise to the fact that they are bringing a lot of other providers to start using the system. And all these three implementations, one thing is common. None of these implementations are easy, and I'll tell you why in the next few slides. But it's worth the investment, some of the payers felt, because the clinical and administration costs that they're seeing, the reduction of administration costs are sometimes up to 60% comparing with what they're doing today. So we are gathering all the metrics. We are asking those customers to share it because they don't want to give it to us all the details. But probably sometime next year they will give it to us and we'll share all the dollar value there. But even in this case, the bottom line is auto approvals, and the middle line is number of auth requests they're submitting every day or every month, and the top line represents the number of back and forth transactions. Everything is automated. And between these three customers, you have seen both elective procedures, you're seeing the inpatient as well. Right? Inpatient is where the money is, they say, some of our payers say. So Highmark started with inpatient. Cambia started with prior auth. So can be done, right? And a lot of toil. So now I'm going to go through some reflections. I'm not trying to create a controversial statement here, but this is out of real pain of spending millions of dollars over the last 5 years at MCG. When we are implementing these with payers, they would like to see ROI. Not after 3 years. They wanted to see in like 12 to 18 months, right? Value is important for them. Like if they're spending millions of dollars on modernizing, they wanted to see how much administration cost I would save, right? They're accountable to some board at that point. At the same time, they wanted to comply with the rules that are coming in, either from CMS or HDI2 and others. So in the process of driving the value, many times I felt that we are going in opposite directions. We are trying to move the needle on compliance, but we are creating solutions that are perhaps not scalable. Because the standards are emerging as well, right? We don't have perfect FHIR specs for prior auth. They're still evolving, and they're not required to implement because of the maturity of the specs. They're still recommended. So you're going to go to a payer and provider to talk about all these things, and they have no idea what you're saying. But there is a deadline on 2027. Somebody has to prove something. So when we approach both payers and providers, we are very open about where these standards are and what we can do. It feels to me as of today that where we're making some progress on compliance side, perhaps we're making a backward progress on scalability side. And I hope in the next 2 years, as the HTA2 proposed rule and the final rule comes up with some recommendations, and we all jump on the specs and EMR support the FHIR standards, we'll make some progress on scalability. But at this point, it doesn't look like that. If any of you disagree with this, I'm open to hear your thoughts as well. So the challenge, the reason I said the scalability part, and I'll prove with you in the next few slides. For the providers, it's not just one connectivity option. Though we say FHIR is the future standard and HL7 still is in place, there are a lot of other options that are coming up, right? We think about X12, HL7, now we have QHINs. It is just a new concept, still evolving, and that would be the best solution if it is in operational. And then you have Epic coming with their own pair platform to connect with all their providers. That's another connectivity. You have portals, you have a lot of other vendors, you have clearinghouses. For providers, even though we are saying that everything works within EMR, native experience, but there's still challenges with which connectivity option should I pick, right? Epic certainly has advantage, right? Their payer platform perhaps offer a lot more data than what you would get with USCDI. So you still have situations for providers to deal with what is the best connectivity option. The more options on the table, it is not going to be scalable. Right? If you're adding another layer on top of EMR, all of a sudden you're limiting the factors. Same thing with the payer side. I created this slide last night, and I have a lot of respect for Hans, who is here from, he's in the industry, very thought leader. We both talked about this for many, probably now years, about the challenges of EPA, electronic prior authorization. So what I would like to outline in this slide is the challenges with the scalability aspect, right? So I put the legend on the right side. So when we did the implementation with the 3 payers, we had to use a little bit of everything because not everything is in place as the DaVinci spec says, as some of the rules are proposing. So if you think about CDS hooks on the HL7 DaVinci, where the provider is supposed to support when the order is placed, it automatically creates an event to the payer. That is still in construction. Nobody is supporting this yet. Right? We don't have even a timeline. Epic is saying sometime later next year. The moment, they release, and then after that they implement with the provider, and then we start using it, it's going to be maybe 2-3 years. Then you move to the right side, between CRD and DTR and PS. These are the, does it require prior auth is a CRD. So if you go to a payer and implement that part, you're talking about sometimes, we went to a payer recently, they said, I have 10 different systems to answer this depending on who is the member. And you're expecting me to give one endpoint to you? And he said, it's not possible. Talk to me after 18 months, they said. So eligibility is still X12, but you have to still talk to multiple systems. To answer the question, does it require prior auth, you have to check the eligibility, you have to check the benefits, you have to check the provider in network or not network, and you have to check whether this is in the PA list that requires prior auth. They're all different systems. They're all using different standards. The X12 and EOB using custom API. The provider, some of the people started using the FHIR standards, some of the payers. But you see the mix of these standards that need to be connected in real time is a heavy lift. That is when I'm saying that, the earlier presenters talked about, hey, use what you already have, X12. In some places, definitely. Some places, you don't have anything. You have to just ask payer, hey, give us a custom endpoint, custom API. And then the FHIR is still evolving. If you go to the DTR, I don't think anybody has this in place, in my view. Right? They're still trying to figure out, how do I convert my policies into a FHIR questionnaire? That's a huge lift. I mean, when we talk to the payers, a lot of technical people talks it as I'm from technology background, but I have been in the industry for a few years. I understand how complex is the nature of clinical integrity when you convert these things into technology. So when you're trying to convert a policy to a FHIR questionnaire or a CQL, it is not just a technology problem. There is a clinical domain expertise problem as well. How do you ensure what they're saying in your criteria represents in your CQL? Is a difficult question. Almost to the point, MCG, we are in this business for 30 years. We know how that would work. And we spent millions of dollars last 2 years to figure this out to operationalize, and we couldn't. And I don't expect some of the payers who have hundreds of their own policies to develop CQL. That is still evolving. Then you come to PAS, right? There is a nice, in the 20 CMS proposed rule or CMS final rule, they said, this is one thing they would like to achieve sooner. Let the status go back to the provider immediately, if nothing else. If it doesn't require prior auth, can we share the status? Today, a lot of people use X12 for that. And we don't have even a mechanism to write back to EMR today. Even I know the status on the payer side, from the FHIR standards point of view. So we still have to figure out where to put that status even I send it back in FHIR format. Because if you start transaction in FHIR and you send back a FHIR transaction, you cannot write back. If you start with X12, yeah, of course you can write it back. But as you see it, we are using X12, FHIR, and custom. Between all these transactions, it is quite a bit of a challenge. So the PS has other things like subscription and inquiries and CDEX. So my point here is that when we do these implementations, we do understand these challenges. And you have to really offer payer kind of a custom solution. I hate to say that, until these specs evolve, until these certifications, and I'm really banking on the certifications one day. The HTA2 will come and say that we are going to certify payers and providers. In my view, that is the only way to confirm some level of standardization. Until that happens, payers are saying that I'm still spending a lot of money on my administration cost. Forget about the clinical side. And then we are thought leaders in the industry. We have to do something. We can't just wait thinking that none of these FHIR standards will evolve, none of these things I can do. We just have to help the healthcare industry move in the right direction. So that is where we have picked up the battle. Like, it is tough to implement, but we have to be open and transparent to the payers and providers. This is going to take time, but you will see the value. When we have done with Highmark, we grossly underestimated to some extent what it would take to implement. Because you don't really know the payer side of the systems. You're just telling what you think will happen. But when all of a sudden the payer side systems have to communicate how much time they would take, and all of a sudden it blows up the timeline. So what we learn in this process is you have to go to every payer and talk about the 3 implementations or the implementations we have done. We are happy to share our experiences. And then bring them to the table. And then you have to bring the providers to the table as well, who are their top providers they want to start using. Without that marriage counseling upfront, if you're going too far, we're probably making some promises that we can't realize. So that is our experience. You bring both sides together. You make them part of the problem and solution. Because if they think vendor is the solution for the interoperability, it's not going to happen. It has to be all 3 parties, right? I have seen that working, and I have seen others who are doing it, doing a great job bringing the whole industry together, sharing these experiences as well. So, at this point, the best solution we have is a hybrid interoperable platform. I hate to use this word, but that's where it is. If you're waiting for a pure FHIR, it's going to be years. If you want to just do it X12, you don't have all the pieces. That's my personal opinion. I'm not, judging X12 here. But you still have to comply with FHIR base. If CMS and HTA comes at some point, FHIR is required. That's what it is. And then you still deal with custom APIs. Yeah, they're not going away, in my view. Because there are a lot of pieces in the payer side still don't have standards. So it is a barrier to adoption, but it is the best thing you have. I believe in the next 2 to 5 years, you will start seeing some of the standardization will be in a good place, like especially with FHIR. Okay, having said that, I don't know how I'm doing at the time. How many minutes I have? 5 more minutes? 17, okay. I'll share some customer insights. I want to leave some time for questions as well. It's a lot of words here, but there's a lot of positive feedback after all the 9 months of recent implementation with Highmark. It is painful, but they have been in production almost now 6 months, Brandy, yeah. Things are working well. They're seeing a lot of administration savings, and they will share in some of the next few conferences. Some of the things they mentioned, I think it is in the next slide. Challenges in scaling workflow efficiencies. They still see resistance to change is one of their big factors, right? When they started implementing with their own provider network, they have seen challenges. And imagine if they have to go to the outside network. So they still see a lot of work in progress. Let me see what else. Continued investment in scaling. So they believe one of the comments they made was that, we wanted to see EMRs play a critical factor in this. And they started approaching Cerner and Epic and sharing their pain points for their own providers. It is very interesting when you have that kind of conversation and a payer is like, hey, I want to talk to the EMRs, what they can help with us. And we had recently one meeting with the Cerner folks, with the payer. And it was very fascinating because I don't think anybody is rejecting the idea that this is a good solution, but the resources, the competing priorities, the challenges, it's a problem for them. So bringing everybody to the table is one of the best factors. That's why in organizations like WEDI, the HL7, and I strongly believe in them, right? I mean, you all coming here is a huge factor for that, because when we talk together, we are moving the industry one step forward, right? We are the ones who have to solve these problems, right? So WEDI does a great job in that context. Here's some of the, these are the first quotations we kind of recorded after they've gone live, because we felt like in the first 2 days, whatever they say is important. When a provider have seen first time an auto approval, that is the first comment. Like they got the authorization ID the moment they clicked the button, like within 2 or 3 seconds. And that person like blown away, never seen anything like that in her history, right? It's worth using some of these comments to motivate others, right? We capture all these things and we share with our customers. And we allow them to talk to each other because they don't trust us, right? They think we are marketing. Of course we are marketing. But we will let providers speak to other providers. The EM staff speak to other EM staff because they can share, what their experience is. The other piece we heard from the payer, I love that I can see all of the nodes in clinical data. One of the best things FHIR does is it gives the structured data. What does structured data do? It enables automation with machine learning, artificial intelligence. And when you get the data in JSON, and when you use a program to just dissect that and put in a lake that you can run some algorithms to see the insights of it, you don't need to touch it. And that's what everybody's excited. We work with a lot of the Cignas and Humanas and other big organizations. Everybody's creating these data lakes. When you have the data coming through FHIR, it enables that kind of structured data sharing. It's not a PDF, it's not the old images. So as much as you can get the structured data that enables automation. When they get that kind of data, they can create more rules on the payer side to see if I'm getting this kind of data from this provider for this and for that, I can automate this because 90% of the time I'm approving those things anyway. So this is kind of a dynamic rule concept you will see in the next 5 years. The more data the payers would get, it enables them to process that. And we see some of our payer organizations already started using some of this data for that purpose. The static rule creation doesn't work in the long time, right? If you have a rules engine where you say, if this diagnosis code from this provider, do this one. I mean, it's still manual. You still have to do a lot of handiwork. But what machine learning offers is that dynamic rule creation. It tells you what you're doing when you approve, and it gives you the patterns. And it suggests you in the future when you get a similar thing like that, hey, instead of spending 15 minutes review time, you already approved this kind of things 80% of the time. Do you want to auto-approve? Right? These are things you're seeing from LLM, right? Some of the suggestions when you try to email. Those are the things that will come in the next 5 years, I believe. And we are working on some of those things as well. A person said, like, facts and forget. and people are coming with all kinds of phrases part of this experience. I'll leave with a couple of slides. Some of the major challenges we have seen implementing on the payer side is when you're doing the CRD part, these are all the questions you have to think. If it is a human to think, they can go to multiple systems and answer that question. But it has to be a system. It has to be one system need to talk to each other through APIs to resolve this to a binary, yes or no. When you think about all these questions, when we go to a payer, when we ask about, hey, these are all things you probably need to answer. Maybe there are more than this list, but I need a system that can talk to each other, all these things and resolve, right? So you need to consider all these things. And this is where we spent most of the time. We didn't spend most of the time on DTR. This CRD is the pain. And then same with the provider implementation side. What ID you would use. How do you resolve that ID with what you have on the payer side? Finally, it's all about money, right? So whatever we say it is approved, it has to connect to the billing and claim systems. Right? That is still, we couldn't answer this question logically every time a payer asks this, right? We still work with them and say, hey, let's figure this out. End of the day, it has to connect with the claims. So I hope it kind of helped you to get some context of what we have done, and happy to answer any questions. Brandy and Donna from our team, they're here as well. They're the brains behind the solution as well. Questions, comments?
Thank you, Raj. We actually have a question from the virtual group. You've mentioned the EMRs a bunch, but what about the RCMs that are connected to the smaller EHRs? So you step outside of Epic, Cerner, Athena, and it's best of breed RCM separate from the EMR.
Oh, I don't mean to separate RCMs and EMRs. I just use the word EMRs loosely in that context.
Yeah, I have a bad habit of asking questions, but you mentioned fax frequently, and I had an interaction with my own physician and, frankly, my own wife, who is also a provider, and said, why do you use fax so often? And she said, and he also said, because it works. It works every time. It never fails. I don't have to log into it. I don't have to verify who I am. I don't actually have to worry about any of it, and it's a safe harbor for HIPAA. So I don't have to worry with all that garbage either. How do we overcome that in providers that are my contemporaries, people who grew up since 1996 using fax and frankly know it works every time, and know that it actually goes from the place they are to the place they want it?
Oh, that's a great question. When we first time rolled out our solutions with each of the three payers and the first set of providers for the respective payer, exactly the same question. None of the users wanted to switch to the solution because of the same reason. We know fax works. And we have to earn their trust. And we spent 60 to 90 days just to proving this would work. So we have to train a super user. This is the approach we have taken. We said, give us one user who can prove this works. Right, Brand, you can add more details to this as well. So we have a 30 to 60 days, one person from that organization start using this as an experiment. Because they could convince them, then we could convince them, right? So each of the time, the 30 days we spent with one of the super user worked, because they went back and created the material they would need to bring the rest of the organization to the table. But it works, they would trust only if it works. And that is a key phrase. And this super user, they have proven that. Brandy, go ahead.
Right. There's also added value for the provider. Receiving that status right away with a reference number. Many providers use that to kick off their claims process, especially the big health networks. Having that status return back to them immediately, whether it's pended or approved, is important to them. And then they also get a decision later on if it doesn't if it's not auto-approved.
Yeah, so the experience we provided them is, in EMRs right now, they have a single click fax button, right? They click it and it goes. We replaced exactly the same, right? We didn't create anything magic. We said, you can still click the same button. Instead of fax, this is sending to the payer electronically, right? So from that viewpoint, they're not really changing anything, because EMRs are not still supporting CDS hooks, so we still have a mechanism to submit it. And the beauty is that when they click it, if they see something immediately right there in the same EMR workflow, for them it is a bigger value than a fax coming in, because they still have to enter that information to the EMR. So some of these workflows, they will only trust when they see it is working. So we spent that time and energy, and it was not easy, and I will tell you.
I have a follow-up from the previous virtual question. Did MCG work with any RCMs as part of their piloting? I'm just curious about where the RCMs are on the Fire versus X12 spectrum.
MCG has not worked with any, did we? Mike is second.
I can't remember the RCM, but yes, we did.
We did? Okay.
Yes.
Yeah. We want the
We'll find out for you.
We'll find out. I know Epic, all scripts, we are working with Cerner and Meditech right now. But yeah. With that, thanks for your time. Let me know if you have any questions after the session.
Excellent. Thank you, Raj.